really excited to introduce our speaker, Dr. Tyler Seibert. He's an associate professor at the University of California, San Diego in the departments of radiation medicine, neurology, bioengineering, and radiology. Clinically, he is a board-certified radiation oncologist, and he cares for patients with aggressive, localized, or metastatic prostate cancer. Dr. Seibert also has a PhD in bioengineering with a focus on quantitative imaging. He serves as the co-director for the Center for Translational Imaging at UC San Diego and founded the International Quantitative Prostate Imaging Consortium, or QPIC. He is a clinical translational scientist and leads a research team focused on tackling real-world clinical problems through engineering approaches. And his laboratory efforts center on three fronts. One, developing advanced quantitative imaging biomarkers for prostate cancer, with the goal of applying these for detection of aggressive disease, precision radiotherapy, and assessment of treatment response. Two, developing predictive genetic risk models to guide clinical decision-making for prostate cancer. And three, conducting clinical trials to improve cancer treatment. And on a personal note, I remember back in the day when I interviewed for residency, and I had a really wonderful time interviewing with Dr. Seibert, and we had some great discussions about different MRI pulse sequences. And I'm so excited for him to join us today and teach us about imaging for GU malignancies, focusing on prostate cancer as one of the lead experts of this topic for radiation oncology and GU malignancies in general. So thank you again, Dr. Seibert, for joining us today.
Thank you. That was very kind. I remember that interview day as well. So, prostate MRI for radiotherapy treatment plan. We're going to focus on MRI. Obviously, people do things with CT. Maybe you mostly do things with CT for prostate. That would be pretty typical. But I'm going to try to convince you that you shouldn't be doing that, and that you should feel encouraged that there is a better way and that it's attainable. This is not something that's like outside of your reach, even if you trained at or are training at a place where most of the attendings are still doing everything CT based, which is how they were trained. I mean, that's how I was trained, right? So that's nothing to be ashamed of. It's just time to move on. All right, some disclosures. I don't know if that was required, but just so it's documented. And then let's start with the big picture. So I said you should be doing MRI. Why? All right, here's why. So how accurate are prostate contours on CT, which is what you are probably doing otherwise? So this is one of my favorite studies in radiation oncology. It's old. It's a little bit, quirky, but it's interesting. So there was this Visible Human project where they had a cadaver that was sectioned, like the whole cadaver. This is a slice of human cadaver. And then they CT scanned these slices as well. And then they had the radiation oncologist contour the prostate on the CT. Okay, here you go. So here, for example, this is the prostate. And then here's an example of somebody's attempt to contour the prostate on CT. So that you can see that there are some things around the prostate that look a lot like prostate on CT. It has the same Hounsfield units. CT scans are not that great for showing contrast between different soft tissue structures. So they had, I think, 120 attempts. I want to say it was 6 radiation oncologists, 120 attempts to contour the prostate. And the contours were typically 30% larger than it was supposed to be. So they went big. And still, zero attempts of 120 covered the full prostate. And the median was about 84% coverage. So that's not very encouraging, right? You could say maybe somebody could do a better job and whatever. But I think that the real conclusion from this is that the prostate is not very visible on CT. And having done many myself, that is true. And I won't go into the details too much tonight, but we did another study where we were looking at registering MRI and CT, and we had a bunch of expert GU radiation oncologists weigh in. And the variation between that, attempts to do registration, this is published just recently, was disturbingly high, and shows you that if we can't see it, I don't know. I mean, maybe there's somebody who can, but I don't think so. I think it's a limitation of the imaging modality. And that's a lesson to us that we should be doing something else. Now, maybe it's just small differences and small doesn't really matter that much. It's certainly possible. But here's the study to make you think twice about that. The Mirage trial, it was supposed to be, is from UCLA, um, looking at MR-Linac based SBRT versus CT based. But the kicker was that because they were doing MR-Linac, they decided that they could shrink the PTV margin from 4 millimeters to 2 millimeters. So one of the biggest differences between the two groups was that one had a 2 millimeter larger PTV. And that difference in PTV was enough that you saw clinically significant and statistically significant differences in patient-reported outcomes for urinary and bowel side effects. So if 2 millimeters by PTV margin was enough to get a difference in patient outcomes on this trial, it makes you wonder if, the errors on CT are bigger than 2 millimeters. So the differences that we're seeing between providers may actually be enough to really impact patient care. It's very plausible. And then that persisted even to late effects. So I think that we should consider this as potentially important, and it's free, right? It's just, do we do a better job or a worse job when we're contouring? It's not like it costs the health system more, it takes us time. But once you learn how to do it, it doesn't anymore. So I think it's a worthwhile endeavor, and you're here. So thank you for coming to learn. We also then asked, well, how well do people do on MRI? Is this something that humans are good at or not good at? Especially given that most of us weren't trained to do it in residency in a cohesive way, and most radiation oncologists, I mean. So we did this study. This was the pure MRI study, prostate and urethra on MRI. It was just published like a month ago. It was 62 physicians, maybe some of you, I don't know, 114 prostate contours. And the median DICE score compared to a multidisciplinary expert panel's contour. So 4 of us that reviewed every millimeter of every slice. And the rule was if anybody saw anything that they thought was off by a millimeter or more, we had to review that spot in all 3 planes and discuss until we got to a conclusion. So there were 2 radiation oncologists and 2 radiologists, all very experienced, all subspecialized in prostate, and we reviewed that. So that's the reference. The reference is what the 4 people decided. And, the participants did a pretty good job. And even people who were still in training were doing pretty similarly, honestly. There were a couple of outliers, but on average, they were doing pretty much the same as people who'd been in practice for a while, which I find quite encouraging. So that's why I said, this is not a task that you can't do. You can definitely do this. You can probably do it as well as your attendings. The variation, maximum error deviation inside, we also reported outside, but so how much did you, at some point in your volume, did you go cut into the prostate and not include that part? That's a little less encouraging. So even though the DICE overall is really good, there were some errors that were as much, it wasn't super uncommon to see errors in the 4 millimeter range. And sometimes we were even seeing a centimeter. So, if that's not where the tumor was, then maybe you're okay. But if it was, that's really bad. So something to think about. I think we can do better than just okay. But okay is still probably right now, we can just give you a prostate MRI, especially at the end of this webinar. You can just start on prostate MRI, and you will be better than anybody is on CT. We also created an AI tool. That's all the rage right now. You can't even publish a paper without thinking about this, right? So we did an AI tool, and it did better than the physicians. Not tremendously better than the average, but better than some of the outliers. And so we think that this could also be a path forward to helping people just in terms of education. You're all here. It would be much harder to get a bunch of attendings who are generalist radiation oncologists who've been in practice for 15 years to come to a seminar and learn how to do MR-based planning, right? All right. Urethra. The urethra might matter. I say might. There was a really nice paper from the FLAME trial that showed that there was a strong association between the dose to the 10th of a milliliter, of urethra, the near maximum dose to urethra, and the probability of GU adverse events. So that was pretty interesting. Of course, that's an association. It's not, it's not causal necessarily. Could be. But also could be correlated with, like, say, how large the tumor was, for example. Maybe larger tumors are more likely to be close to the urethra, and maybe larger tumors, larger treatment volume treated also led. So I don't know. But a lot of people believe that the urethra could be associated with adverse events. Certainly sounds like it could be in terms of stricture. So it's something that we care about. And all of the guidelines would say that you should control urethra dose if you're going to do focal boost. So we also included on that pure MRI study the urethra. While the prostate was encouraging, the urethra was not encouraging. Again, 62 physicians, 110 contours, down from 114 for prostate. Why? Because a couple of the participants just said, it's hopeless, I can't do it. And they just did not contour anything. So we excluded those. But yellow is what the expert panel agreed should be done. And blue is like, this is an example from our AI model. This is an illustration. This is not necessarily typical. Hard to say, but it was an example of where things could go wrong. So here's one that went okay. It was just really big, but they pretty much covered the trajectory of the urethra okay in green. That was a physician. Here's one where things went wrong and they went posterior. I can show this and people will look at it and say, well, that's really bad. That's cherry picking. That person just doesn't know what they're doing. Fine. But the question is, can people in general do it? If it's really easy, everybody could do it. Nobody would miss where the bladder is, for example. That's not hard. And this is harder. For what it's worth, when I was trying to figure out how to do this early in my career, I went to go find a paper in the literature to show me where the urethra was. And I found one. And I was looking at it, and I looked at it again, and I looked at it more closely, and then I was like, I gotta go to bed and just think about it. I went the next day, I looked at it. Finally, I sent it to a couple of radiologist friends, and I was like, am I crazy, or is this urethra actually not the urethra? It's going into the seminal vesicles, not into the bladder. And they said, no, you're right. So the only paper I could find showing me how to do it was just wrong, which is really sad. But it shows you, again, this isn't about people being dumb or smart. It's about, is this a task that's easy or is it not easy? Is it something that we need to make better or not? And this is one that we need to make clearly better. So we did what we could. We evaluated it, and then we showed some things, and I'll show you what I'm thinking. I think we can make things better, but it is fundamentally a difficult task, and you shouldn't feel bad if you think that it's hard. So did the panel. And the radiologists are also uncomfortable contouring the entire trajectory of the urethra for many patients. Some it's easy and some it's not at all easy. It's basically impossible to get every slice right. But you can still get close. I will say, though, that this study makes me really wonder about things like urethra dose and complication modeling. Because how do we know if those urethras were really the urethra for that patient? It's very concerning. I don't know how you can tell. But anyway, the DICE coefficient, they're way up here for prostate. For urethra, they're quite low. AI was, yes, better than the physicians, but they're still poor. They're less than 0.5. What's more encouraging is this is a small structure. DICE isn't the end-all be-all of evaluations, right? What we really want to know is, did you cover the urethra? Without making it insanely big. If you just covered the whole prostate, then yeah, you'd get the urethra in there somewhere, but it wouldn't be useful. And so we looked at volume overlap. So what percentage of the true urethra was covered by the contour? And so even though the DICE wasn't tremendously better with AI, the coverage of the urethra was much better with AI, which was encouraging. So from 36% to 81%. And the maximum error away from the true urethra was the same with AI. So it's not like it just was huge. It just was better at following the trajectory. Not perfect, but better. And that's been published as well. Oh, that's weird animation. Sorry, I just made this slide right before we came. I just thought that it might be nice to have some resources. So I won't belabor this, but I wanted these to be easy for you to find. Caveat. So these are 3 papers I just referenced. PowerPoint of example cases from those where it's just in like an atlas of 2 prostate cases and a urethra one. I said it's available on the website because I know this is being saved. It's not yet, but I think it will be up by next week, hopefully in the next couple of days. So if next week you're looking for it and you have a case and you want to do it, email me. All right. And I will, or find me on Twitter and I will get you the case. But those will be available. I also sent 1 or 2 example cases to the folks at eContour, who are going to put it up. They told me, and they also are making an interactive case where you can contour and then have it pop up and see if you did it right. But I guess maybe don't look at the example case really closely before you do the interactive one, or it's like looking at the answer key. Okay, but MRI gives us more than a great view of just the prostate, right? It also, per all of these major papers, shows you where the tumor is, which is why we use it before a biopsy, or should. All of your patients should be an MRI before biopsy. If they're not, talk to your referring urologist and remind them that this is about as strong an evidence base for a radiology use case as we have anywhere in medicine. Just lots and lots of great studies have shown how useful MRI can be for finding the tumor. And then this randomized trial, FLAME, which hopefully you've heard of, but I'll remind you quickly, phase 3 randomized trial in the Netherlands, where they asked a great question, which is, now that you can see a tumor on prostate MRI, remember before we couldn't see it. So there was no question of trying to boost a tumor, like increase the dose. You couldn't see it on CT, so who cared? Now you can. So maybe we should intensify the dose just to the tumor. And we should do it in a way that's safe for patients. So they randomized patients to either 1 dose to the whole gland, or same thing, but a simultaneous integrated boost to the tumor, the visible tumor on MRI, as high as you could achieve without violating the constraints or guidance for dose. So some patients got a big boost and some didn't get any boost at all in the experimental arm. Nonetheless, disease-free survival was much better in the focal boost arm. And that led to local failures that were 3 times less likely in the boost arm, despite the dilution of the effect, because a lot of them didn't get a good boost. And regional and distant metastatic failure also had an adjusted hazard ratio of 0.56. So we're cutting that almost in half as well. And that was all achieved without any difference in patient-reported outcomes. So that's a home run, right? I mean, if you tell a patient, we can treat you the same number of days, you won't know. This is a blinded trial. They didn't even know which arm they were on. We can treat you either with this focal boost or not. The only difference is you're more likely to be cured if we do the focal boost. And that's a silly conversation. Every single patient will say, yes, please. And yet, the latest evidence, both from a survey we did and from a nice study from the group in Michigan that has, statewide data, it's a minority of patients that are getting this. Hopefully you're doing this in your training. If you're not, look around and learn how to do it. It's not impossible. And something that I think that we as a field should be delivering for our patients. We have level 1 evidence that this is beneficial without causing undue harm. And it doesn't cost the health system any extra money, at least on the table. You do have to put in more effort. So that counts for something. Our effort matters. But I think this is something we should be doing. One of the problems, though, we suspected would be that it might be hard to see the tumor. It might just be that none of us were trained to do this. And MRI for prostate is hard, which is why radiologists who aren't experts don't want to do it, and don't do it. It's really something that requires some training. So we asked, what about radiation oncologists? We're not being asked to decide who needs a biopsy. We don't need to distinguish patients who have and don't have cancer. All of our patients have cancer. But we need to find this tumor. So we asked a question in this study. We had 44 participants. They were all radiation oncologists. They were given prostate MR images. We told them where the tumor was. So they didn't have to do the radiologist job. The radiologist report said there was there's a PIRADS 4 lesion in the right posterior peripheral zone at the base of the gland. It was 1.2 centimeters. Now circle it. And they tried. And half the time we only gave them conventional MRI, and half the time we also gave them this experiment, this quantitative imaging map that we've developed here at UCSD. And here red is what they were supposed to target, and blue were the different shades of blue are the different attempts by various radiation oncologists to hit the target. So they were in the neighborhood, but it really wasn't very good. For a lot of them, those same people on a different occasion, not being told that they were seeing the same case, were able to hit the target pretty well when we gave them the advanced imaging. So obviously, I mean, this is my research project, program here developing this. So I would love for everybody to have this. We're working on that. But my point really with this for you guys is this is hard. And my first recommendation is if you're doing it, look at the image. Ask them to put arrows. Ask them to contour it. They contour it for urologists for biopsy. The problem is that most of our centers use software where that doesn't become available to you as a radiation oncologist. So ask for it to become available, or ask for them to contour it, or ask them to put arrows on it in packs so that you can see when you pull up the images. But I think this is important for our patients, and it's a reasonable thing for us to ask of our colleagues. Here's another case example. 18% of attempts on that study were complete misses where they didn't have a single voxel overlap with the true target. We lowered that a lot with the quantitative biomarker. But again, I know that's not widely available for everybody. The point really is that you can get this wrong. And I encourage you to do a better job by getting help until you're comfortable or you know where it is. Does it matter? It could. Here's an example. These are patients where we planned them lots of times. We plan them for each contour. So each participant's attempt to contour. So here's an example where the X is where if you contour this patient 3 with the expert contour, then there's about a 4% chance of biochemical failure in the next 5 years, according to the FLAME trial data. We got the model from them. It was very nice of them to send it to us, and we did that based on the dose to the tumor. But most of the radiation oncologists are giving that patient an 18 or 19% chance of recurrence. I mean, this is a modeling exercise, obviously, comes with some caveats, but that difference right there is bigger than the difference you get with it giving patients ADT or not. And the only difference is being accurate or not being accurate. So I think it's worth, again, trying. And then here's what we're thinking about the future. What would you do with this information? Well, if I had a good way of seeing the tumor back in whenever they started doing prostate radiation, I don't know, decades ago, what we would have done is really gone after the tumor. And maybe we would cover the rest of the prostate too, but we wouldn't have been taking it all to the same dose. Nobody would have even thought of that being the key plan, right? It's just what we've inherited because we couldn't see things before. So now what we're doing is asking a question in a randomized trial. What if we lower the dose to the rest of the prostate? And the reason for that is on FLAME, I will fly through this a little bit, but on FLAME, if there was a recurrence in the prostate, it was almost always, truly almost always, in the original spot that was visible. Okay? So if that's true, then we should be able to get away with lowering the dose to the rest of the prostate, which potentially could lower side effects. And here's an example. So if we were doing a 28 fraction course for this patient for various reasons, you would do normally 70 and 28 to the entire PTV, right? And then we would boost up to, say, 84 gray and 28 fractions to the GTV. And the randomized trial is saying, well, do that, or same boost to the tumor, add 5 millimeters around that within the prostate, and give that the full dose, what was normally the prescription dose, 70 gray and 28 fractions, and lower the rest to 56. And what that does is it really just lowers the dose to every other organ, the urethra, the bladder, the rectum, everything gets a much lower dose, which if there are dose-dependent side effects, then that will lower those. That should be true, and that's what we're testing in the randomized trial. So that's ongoing, and some food for thought for you. A few words on logistics. ADT changes the prostate. I mean, you probably all know that. If you haven't done a GE rotation, maybe you don't know that, but you will see it. It changes it a lot. That's well known. But if you want to see the tumor, you need to get the MRI before starting ADT. Okay, so if they had one before biopsy, great. If they didn't, you need to order it. If it was a long time ago, then you should probably do it now, right? And no barriers with insurance. I have not had any insurance block me getting an MRI for treatment planning in the last 5 years. Zero. It's easier to get an MRI for treatment planning than it is to get one before biopsy, which is crazy because that's where all the trials are. But anyway, the answer is you should be getting it before biopsy. But if somebody forgot or didn't do it, you still can. The second thing, though, is I just showed you that to see the prostate well, you need MRI. CT is not going to cut it. So if you do neoadjuvant ADT, 6 weeks, 8 weeks, something like that, which is common, maybe they were starting ADT before you even met them, then you need to do a new MRI. I know that sounds like a lot of MRIs, and I hear you, which is why I prefer to just get the MRI once and then start ADT at SIM and do everything together. But sometimes you can't for various reasons. And if that's the case, then we get a new MRI, because what I showed you at the beginning is that if you over contour based on CT, you're spreading dose where you don't need to, and you might be missing some of the prostate as well. You probably are, based on that first paper I showed you. MR to CT registration is another potential issue that can be tricky. We just published a paper on this a few weeks ago. You can take a look at it. I mentioned it earlier in the webinar. And then contour the prostate on MRI first. This is just my way. This is how I handle the registration. I contour the MRI on the prostate. Contour the prostate on the MRI. And then I fuse the two. And then I have that contour. I know where the prostate is on the MRI because I drew it. I go just to where I can only see the contour of the prostate, and I move that circle, sphere, whatever, onto where I see it on the CT. That works pretty well. Is reliable, and it's quick. And I don't know. That's my suggestion. I can't say it's proven, but works very well for me. And then, of course, I don't do all of this alone. I mentioned a lot of evidence that we've generated, and so I thank my collaborators and the funders and donors and study participants. We can't do anything without them. Very grateful for them. And I will say, hey, this is a good opportunity for us to get to know each other. And if you see something that's interesting and you have an opportunity, come out here, collaborate with us, etc. And with that, what I'm going to try to do now is move over to the other computer and share that one. Let's see if I can pull it off. It looks like it worked. You see it?
We can see it.
Okay, great. Okay, so I promised that we would have time for questions. We're doing pretty well on time right now. I'm going to stop for a moment and then say, does anybody have any questions that you want to ask before I do an example case? Because my next plan is I will show you, I'm going to contour this prostate and urethra and just kind of talk aloud to tell you what I'm thinking when I'm doing it. I can start with that, or I can take questions, either way. No burning questions. You can put them in the chat too, or you can unmute yourself and just talk. Like I said at the beginning, I would much rather this not be just me talking into the void.
For your RSI sequence, how is that different or provide better contrast or delineation than other diffusion weighted imaging sequences? Like what's the magic of that sequence, or what parameters are you changing to get such a nice image and contrast for your Radonx contouring?
I purposely didn't show you all the slides on RSI and everything. Of course, I've given many talks on that because I didn't want this to be a promote my research talk. This is more of a practical,
Fair.
contouring. But I couldn't help with avoid the Reignite study, and so I've shown you now. But why it works is because it's a biophysics-based quantitative imaging biomarker. We collect more B values in the same acquisition. And then we have a model that resolves the signal into different micro compartments. So the one that you really want to focus on is the intracellular restricted diffusion. That's what most will highlight cancer. And so we do that, and then we normalize it so that it's quantitative, and that suppresses everything else. So you end up with something that's definitely not perfect, but is often really, really good. And it's quantitative, which means that you can just ask, like, what is the maximum RSI restriction score value in the prostate, like a maximum SUV from a PET scan. And that works really well. Like, I mean, it's pretty comparable. In our studies of patients who went to biopsy, it's comparable to PIRADS. Even though PIRADS is based on multiparametric MRI and it's expert radiologists who are using, 35 minutes of scanning, we've got a 2 to 3 minute scan that's doing as well without any thought. So that's really good. It's being evaluated in a prospective trial for diagnostic radiology, and it's also incorporated into that rad target study I told you about. And we are soon to do a study on contouring where we see how, like, I did the one to see if you missed or not. Now the next one will be, how well do we all agree? Like, do I contour it and you contour it, and do we get the same answer? And how well does that line up with what the radiologist said, and even better with what whole mount histopathology shows us in patients who went to surgery? So we are going to launch that study sometime in the next few weeks, probably. So if you're interested in participating in that, reach out. We'll open that up to people who, radiation oncologists who are interested in. It will be some work, but there will be also recognition for that work, and we'll see if we can learn something good together.
Great. Thank you so much, Dr. Seibert.
Yeah.
Hi,
Okay.
Dr. Seibert. I have a
Yes.
question for you.
Mhm.
It's also regarding RSI, MRI. For like regarding probe trial, like how do you think like would be the concordance with as compared to like PSMA PET of the RSI MRI in terms of especially in terms of localizing it in
Mhm.
where it is located?
Yeah. It won't be exactly the same. I can tell you that right now because I get MRI and PET on all of my patients. So I've seen lots, but I will reserve a final answer until we can analyze our data. So what we're doing now is we have 2 studies that are funded for looking at MRI with RSI or without, either way, and PSMA PET against whole mount histopathology. So then we'll be able to look quantitatively, how much do they overlap? When is there a difference? If there is a difference, is it more likely, less likely to be cancer? And if it's likely to be cancer, is it higher grade? Is it cancer we care about? Or is it like grade group 1 or grade group 2 non-cribriform that I don't really care about? That kind of thing. So I think that we don't know the answer quite yet, but we're working on it, and we will have a good answer. The other thing I will say is that right now, what we should be doing is hitting the MRI visible tumor, because that's what FLAME showed us. FLAME showed us that hitting the MRI visible tumor with an intensified dose improves patient outcomes. Everything else is conjecture. So one thing that you might ask yourself is, well, I've read lots of papers where MRI shows the tumor, but it's smaller on MRI than it is on histopathology. That's true. I mean, that's every study that's ever been published on it, basically, or at least the consensus across the studies. But it's also true that there's a dose gradient. If you put a GTV and you boost that thing, there's no way that 1 millimeter over, you've got a low dose. It's hot, right? And so what we know is that boosting as much as you can to the GTV and having some dose gradient does the job that we want it to do, and that there aren't very many local recurrences at that point. And so you're doing a really good job. What we could be tempted to do if we start to look at adding PSMA PET or, adding a margin around because that the tumor is often bigger than it is on MRI, we're kind of going beyond the evidence at that point. It's logical, but it's also a little bit dangerous because we might end up just making bigger targets and not helping patients any extra unless we test it in trials, which is why our approach here with the one that I showed you is I said, I'm going to lower the dose outside, because that actually goes really nicely with the FLAME trial, that there's some low-hanging fruit. We might be able to make things better. The intensifying the dose beyond what they did on FLAME, I mean, maybe you can help, but the local recurrence rates are so low that you would need a really big trial to show a benefit. Expanding the volume of the tumor might help, but not very many patients, because in patients who had a local recurrence, like I said, it was usually in the GTV or overlapping with the GTV. And there was one that recurred right next to the GTV. So that would be the one patient where you would say, okay, well, in that one, maybe a margin would have helped. But that's 1 out of 571 patients. So again, imagine the trial you would have to be designing this to get any kind of an effect size to help one patient in 571. Okay. Is that fair?
Thank you.
Yeah, you're welcome. All right. That said, I do look at the PET, but I try to stick to the size of the MRI. I use the PET to help me find the thing. And I always, and this is really important, I always look at the pathology report very closely. So I'm not going after, we know MRI can have false positives. I'm not going after every blip on MRI. I'm going after the thing that was corroborated on the biopsy. That's what I'm boosting. All right. So I always look if there's a PIRADS 4 on the right and a PIRADS 3 on the left, and the 4 came back with Gleason 4+3, and all the systematic cores and targeted cores on the left were 3+3 or lower, I don't boost that. What's the point? All right, so here's a case. I'm going to contour the prostate. We've got, how much time we have? 18 minutes. All right. I always look at all 3 planes. Can I move this out of the way? Oh, I can make it a little smaller. That's at least something. Nope. I put it over here. Perfect. Okay. Always look in all 3 planes. I'm particularly interested in the sagittal plane, basically when I'm contouring anything. And I like to use the brush. We're trying to get to the edge of the prostate. The rectum should be fairly obvious where that is. I just bumped my hand. I'll make this a little bit smaller. So MRI, muscles are dark. The capsule is dark. The prostate tends to be bright. Something, if you've only looked at CT, that you may not have appreciated is it has zones. I mean, you've heard of them, right? But you can actually see them on MRI. So peripheral zone tends to be brighter. That's not as true in patients that are younger. It's a feature of aging. It's a very useful feature because tumors are dark. And so the peripheral zone is where most of them are. And if it's bright and then the dark tumor, it makes it stand out more. So it's convenient. The central gland, which is mostly transition zone, is harder. It's more heterogeneous. The tumors are not as obvious. There aren't as many of them, but when they are there, it's harder to find them. It's harder to biopsy them, depending on how you're doing it. But in the traditional transrectal way, they don't tend to sample the transition zone very well. So some things to think about. So I usually go right in the middle. I'm looking at the sagittal to make sure that it makes sense, to make sure that I don't have some kind of weird zigzag. I'm going to get rid of that and make this a little bit bigger because we don't have that much time. There's an anterior fibromuscular stroma. That's that dark stuff that I'm showing you right here slowly so you can see. We have to get back here and get the peripheral zone. And then I went too far up here. This stuff in the front, that's the dorsal venous plexus. It looks an awful lot like I showed you before, like prostate on CT, but it's not. And then on this corner, I'm a little unsure right now on this one, so we're going to come back to it. The one other thing that you'll note is that on MRI, you can get partial volume effects. So most of you are going to have 3 millimeter thick slices, and things can change a lot in 3 millimeters. So if you might see that in 2 slices, you kind of see 2 different kinds of tissue. So here, clearly this is fat. And the next one up, kind of hard to tell. Like this looks kind of prostate-like, but this doesn't. It could be neurovascular bundle. The next one up, you can see this is prostate. And so what we have is probably something in between here. And then just to be safe, I'm going to take this, but I'm not super convinced about it. But because it's kind of part of that tissue and part of the one below it, we'll just err on the side of caution. And I am trying to go fast, not to make excuses, but I know you're all watching me and we need to get to the urethra and everything. So take it with a bit of a grain of salt. I stand by the ones we published. Those I poured over. All right, and so I'm looking over here at the sagittal, and you can see that it's smooth, slice to slice. If you sometimes what you'll see is like if you, I'll show you for example, if I went a little different on one, then you get this kind of weird point. And that's okay, it might be real, but you should take a look at it. I mean, that probably actually is anterior fibromuscular stroma, which can pooch out in the front. But then you get up here and you're starting to be in bladder muscle. Muscle again is dark, as is the capsule. So those tend to blend together. The bladder neck, as it's coming down, bunching up muscle, that is dark. And then the other thing about prostates is in the patient age that we're seeing the cancer in, they often have BPH, and that BPH can grow up into their into the bladder and the bladder neck and above and whatever. And so then you get weird shaped stuff. We'll go look at that in a second. And there's this patient has a lot of bright things on the left anteriorly. I don't know what it is. We see it on the whole mount histopathology. It's basically like extra fluid, but don't ask me what it is. What happened to this guy? Why does he have that? I think it's probably some kind of atrophy, maybe some post-inflammatory, but I'm making that up. So like this right here. That's not very, very common, but it can happen. I don't know what it is. It's prostate. I don't know why it looks so weird. And the apex is the hardest part. The base is second hardest. The apex is the hardest. What are we looking for? We see this fat. You have to follow it down. Look at the sagittal. This back here is still prostate. Where does it end anteriorly? Can't really be sure. I mean, we have urethra in here. This is a bit of a grainy image. Maybe the patient was on the larger side. But you try something and then you look at it on the sagittal and see if it makes sense. And I would say that does make actually pretty fair sense. It's coming down to a point-ish, which it should. I always err on the side of, if on the last slice, I would err on the side of including because of that 3 millimeter thing. If you have an apical tumor, then you're in trouble, but you should see that, hopefully. But either way, think of it as CT SIM slices are a little thinner than MR slices, and you have this partial volume effect. Probably okay to do it, especially because the other thing is, and this one's actually going to prove me wrong, it's short, but usually the penile bulb is a lot farther down than you think because CT, it's hard to tell. So most patients, I have a pretty big gap between the prostate and the penile bulb on MRI that I wouldn't have necessarily appreciated on CT. All right. Still think that's a little much. When we get to the top, get something, and then we look, because this, again, this corner I was taking an eye look at. I think we got, again, some partial volume effect. We want to make sure that it makes sense. The next problem that we'll get to is, well, two, at the base, you have the problem of the base just where it goes into the bladder neck. And you also have the problem that eventually you get to the seminal vesicles. And on CT, again, it'll look like the same thing as prostate for a while before they separate. And on MRI, you can tell them apart. But we kind of made just a judgment call rule that since everybody was treated based on CT in all of the trials in the past, we would, if you couldn't see a plane between them that was clear, we would just call it prostate. So you'll see that on the one that we published. We know it's not, but it seemed pragmatic. Here you have seminal vesicles, very clear. That same tissue is here. Now it's touching the prostate, but it's obviously a separate thing. This around it looks like seminal vesicle beginning, and now we're out of it. This is probably partial volume, partly prostate, partly bladder. Again, I tend to err on the side of caution of including when I'm contouring. And then when I'm planning, I might delete a slice that I think is, it's just going to be bladder. The tumor's nowhere near there. We'll take that liberty. And here. How are we doing on time? Sometimes you have to move around a little bit because, the particular slice you're looking at might look funny on the sagittal, but I just moved over a couple of voxels and it looks fine. So it might just be that spot. All right, there's prostate. Urethra. The urethra, I told you, is hard. People tend to miss it. So I'm going to give you some tips, but it may not be perfect. So we start as soon as you get out of the penile bulb. So penile bulb is bright on MRI. And we say as soon as it's very visible. So this one's super very visible here. Borderline, you can include it or not. It doesn't really matter because you're not going to treat down here. And you could really see it pretty well far down. This slice is an ugly slice, so it's a little harder to tell. Here we know that it's going to be around there. And we can just fill in. And this one's not going to be as pretty as the prostate because it's not totally visible. But you can kind of see where it is. You follow it sagittally. Some people like to just go to the mid-sagittal line and do like a 6 millimeter or 5 millimeter or whatever sphere brush and done. You can. It's probably fine compared to what a lot of people have been doing anyway, but that is not what happens for a lot of patients because because the BPH, it causes deviations in the course of the urethra. So here you have verumentanum, this kind of upside down V looking thing that's bright. That's very helpful. The urethra is essentially just anterior to that. And you can tell that if you ever look at a patient with a Foley catheter, that's where it is. It's like a golf ball on a tee. Then you get to here where now it's kind of less visible and it's going to get worse. So now it's going to become hard to see. And I would just say we're going to try. But the other thing you need to do is go up to the top and look for where the bladder neck is, which is not always very visible, but often is. And you need to find that because the urethra has to be connected to the bladder neck and it has to go to the penis. And if it doesn't do those two things, you screwed it up. Like, beware. I've seen it, like I said, on papers. I've seen it on people's contours. Those two anchor points you can count on. Otherwise, how is it going to work? The urine's got to go from the bladder out. So we need to get in there somehow. And often there's a little peak like this, and you can see it both on the sagittal and the axial. That's not urethra, it's just bladder, but I'm going to highlight it for your sake right now and say we know it's got to come through there. And we know it's got to get to this one. So we're going to follow this up on the axial, and we've got to get to connect those points. Is it perfect? Am I sure this is where it is? No. But I'm following to make sure that it at least makes sense. This is actually a pretty bad one. Beggars can't be choosers. I realized a couple hours ago that I couldn't just pull up any case for you because then it would have the patient's name on there. So I had to ask my lab team to get me a case with to de-identify somebody, so we get what we get. And this one kind of deviates quite a bit, but you can see because see the big right-sided nodules on BPH. That means that the urethra has to deviate. And again, I'm going fast because we're going to run out of time, so it's not perfect, but again, this is going to be close. And you could add a margin around it, a PRV margin for your treatment planning if you want. Nobody knows what you're supposed to do, right? Because the dose constraints are kind of made up. I don't like that point in the front, so I'm going to guess it's probably not like that. But we tend to be pretty conservative on our urethra planning, like sparing. So it doesn't have to be perfect anyway, but we need to get something. And that's pretty good. We've got a few minutes left. Now, tumor. To find the tumor, talk to your radiologist and get the picture. I'm not kidding. That's the fastest way. We're not going to be able to do better than that, but I'll show you how I do it. I think you want to look at the diffusion. The diffusion is what shows you where it is the best. The anatomy is best on the T2. Diffusion is distorted, so it can be shifted, and you need to be aware of that, especially if there's gas in the rectum. We've addressed that. We correct it, so the RSI maps tend to be pretty good, but you can't count on that with like an ADC. Here's ADC. You're looking for a dark spot. I think it's this over here. But this is also not on it's got to be that. It's not on the T2, so it's kind of hard to tell. You could compare them side by side, but it's not that great. Here's the RSI. There's the tumor. Not hard to find. And what you would do is make this red because that makes sense. This is also, in this case, going to show me that probably this stuff that I didn't include is prostate. Because I don't think that we see a lot of EPE, but we probably should have included that on the edge, one slice, and this one I just was going fast, but that does look clear, and that looks clear, and that looks clear. I don't think I really need to contour the GTV for you. You can obviously see where it looks bright because of the quantitative biomarker. But what I will say is that what I tend to do is then look to make sure that there's a corresponding spot on T2. And here you can see it. There's this dark lesion that's corresponding to the diffusion. And that is our tumor. So that's what we would boost. All right. Any other questions? Please. I've got a few minutes. I can wait. I see one in the chat. In what settings in your practice do you usually deliver in neoadjuvant ADT? For me, at these days, it used to be just like routinely we did it for everybody. And the thought was that you shrink the target, it'll be a little bit more stable. Once the prostate's gotten small after ADT for a few weeks, months, whatever, that now it's not going to be shrinking anymore. And so it's a more stable target. And maybe they've had some response in terms of like if they have lower urinary tract symptoms, maybe those have improved with the ADT. Now I would say I haven't been convinced that the ADT improves most patients. Some it does, but most don't improve that much from ADT. You're better off starting them on Flomax if they really are having issues. If they have bad obstructive issues, you need to think about things like a TERP if you're worried about having needing a catheter or something, real retention. So when would I do ADT? If we logistically can't get them treated in time. They're going on a trip and they don't want to. They need to have a TERP. They really want a spacer. I don't have strong feelings, honestly. It's another topic, but about hydrogel spacers. But if there's a patient who really wants one and there's a waiting list for the getting in the OR because it's a holiday, whatever, fine. So like for logistic reasons that are patient driven, basically I would start ADT first, but my preference is to not. I've had other patients like insurance. They're changing insurance in January, and we're not going to be able to start their treatment until January 3rd. We better just wait to do everything in January because otherwise you got to switch. It's too complicated. For that kind of reason, I would do it. But most commonly, the reason that they get neoadjuvant ADT is because somebody started it on them for them before I met them. Med-onc or urology that referred already started the patient on ADT. So it's been done, and then I just get a new MRI. It's okay. It's just not ideal. We also have, we just finished analyzing, so this is a little bit, this is confidential or whatever, but we have a longitudinal study where we're scanning patients before ADT, after ADT, and before radiation, and then right after radiation. And the idea was to look at biomarkers to predict long-term outcomes. But with all of that data, we're also able to look at how much does the prostate change with ADT, how much does it change still when they're on radiation after they've had ADT. And long story short, it's very unpredictable, and they change quite a bit, and they continue to change while they're on radiation, even if you did neoadjuvant ADT. So it doesn't seem like you can predict anything. And maybe the best solution I'm starting to think is just start ADT right at the beginning, get the treatment done fast. And if you're doing SBRT, you'll be done before it even shrinks. So, that might be the best. Some other evidence from Dr. Spratt at Case and University Hospitals showed that there's some evidence that's the adjuvant period of ADT that's most important anyway, in terms of oncologic outcomes. And so if that's the case, then you could argue that if you're going to do a fixed amount of time, say 6 months for intermediate risk, that you're potentially better off having most of it be after the radiation anyway. So I don't feel obliged to do neoadjuvant, but I'm not afraid of it either. It's okay. If we need to do it, we do it. Anybody else?
I have a question.
Yeah.
How do you think about flame by comparison to like brachy boost? And like, do you think it's as effective in the right setting? Are there certain situations you would lean more towards one or the other?
Ooh, can I be provocative? I just wrote, there was a debate. You can look at the papers, you can see our full opinions. But there was a debate series in seminars in radiation oncology a few months ago, and I was on the pro focal boost over brachytherapy, and Dr. Hoskin did the pro brachy. So you can read the two, and a lot of good information both sides. And obviously, it's supposed to be a little bit provocative, but I will, in the spirit of that, be provocative. We have one randomized trial in Flame that showed a meaningful, not survival advantage, but a meaningful, I think, patient-oriented endpoint of disease-free survival. But more importantly, in my mind, are the secondary outcomes, looking at local recurrence rates and regional and distant metastasis rates in Flame. So you see a benefit for lowering local recurrence and lowering regional or distant metastasis without any increase in side effects, versus Ascend-RT, that is our one good randomized trial of looking at external beam versus external beam plus a brachytherapy boost. And there you saw not even a hint of a benefit for metastasis, and you saw a lot more side effects. So I think that the onus is on us in radiation oncology to prove the benefit of brachytherapy. And it's dangerous for us to tout the benefits, the hypothesized benefits of brachytherapy without doing the studies, because it makes us a little bit, puts us on shaky ground when we want to make the same arguments or similar arguments about, say, focal therapy. Oh, you don't have enough evidence, you should stick to the standard thing because the randomized trials have shown benefit with radiation and ADT. So we shouldn't do focal therapy without randomized trials. To turn around and say, well, we need to do brachytherapy, we must because the physics are so much better, seems like inconsistent to me. Likewise, you could make the same argument that protons would be better because the physics is better. And then we do a randomized trial for protons versus photons for prostate and see no benefit. So it's an invasive procedure. It requires expertise and skills that not everybody has. And is, I would argue, harder to train a whole lot of people to do brachytherapy than it is to give people some education and AI tools to help them do this. So I'm very much in favor of moving toward focal boost, and would completely support randomized trials in brachytherapy, but short of a good randomized trial showing me that there's a benefit for patients to justify the extra side effects, or a trial to show me that the side effects are lower when you include that you had to do an invasive procedure, which is, a grade 2 or 3 side effect anyway. I almost never recommend it.
Yeah, that makes
Some
sense.
people will
I
not
have
like
a
that answer.
follow-up.
Yeah, go ahead.
I have a follow-up controversial question too, if you
Good. Those are
don't
the fun
mind.
ones.
Do you think that there is a dosimetric benefit to or against protons compared to photons in doing these flame boosts? Like, do you think there's a potential benefit to doing it, or do you think that there's a potential detriment to doing it?
I think we don't know. We don't know, right? I am kind of wondering if I should add some of this prostate here now that you guys are just sitting up on the screen the whole time. Yeah, I don't know. I don't know the answer to that. We know that it worked with photons, and it seems plausible to me that it would work with protons. I have no objection. I don't think we need to wait on a randomized trial to ask, can you deliver more dose to the tumor for brachytherapy or protons? Like, if you're doing the treatment, I think it's reasonable to extrapolate and say it's okay to intensify the dose to where I know the tumor is. That seems reasonable to me. I don't think you can't expect a randomized trial on every tiny question because we'll never make any progress, right? That seems reasonable as an extrapolation. We all acknowledge it's an extrapolation. With brachytherapy, it's harder to justify why you maybe need to because the dose is so high anyway. If you're doing the whole gland, but maybe you're going to intensify the dose to just the thing. I think that we can have some leeway there and people can make some reasonable decisions, and I won't quibble on it. For the delivery of the protons, can you hit the target? I mean, I think you can if you have the right kind of onboard imaging. Not every center is the same. We have one here. I think that we do a good job of hitting that target. Would I tell any patients that they need protons? No. Why, I've got no basis for saying that. Do I think that there might be a benefit of prostate? Maybe. I mean, I think that some people say that if you're treating the lymph nodes, that you can see less irritation of the bowel. And that sure makes a lot of logical sense from a physics perspective and looking at the scans. I'd like to see it proved in a randomized trial because otherwise you make claims and then people will go out of their way. Like, who's traveling to get protons? Who's paying out of pocket the differential, or, changing their insurance, or, stressing about these things. We shouldn't cause stress in patients to making them think they're missing out on something that we've kind of invented in our heads and haven't proven. So I allow patients on the rad target trial to get protons. Shows you that I'm not opposed at all. They can't get brachytherapy because that would be a completely different side effect profile. So nothing against it, just would be too hard.
So are you
not sure.
SIV boosting everything that you treat externally with prostate, conventional hyperfractionating, SBRT? And you may have already said this, but are you using what's your margin for the GTV, if there is one?
0. Good question.
0. Okay.
And why 0? Because that's what they did on Flame.
Yeah.
And then the fractionation. So there's a question that people have, right? Is, can we, if they use 35 fractions for Flame, do I have to use 35 fractions for the boost? That's a reasonable question. People could say, I don't feel comfortable doing any other fractionation because that's the only one that was done on a randomized trial. I'm okay with that. People saying that, I would not argue with that. I don't think that it's necessary. We have lots of trials showing that SBRT is safe, for example. So if it's okay to give, if it's okay to give 9 gray per fraction to the whole prostate, then I have a hard time believing that, say boosting a 28 fraction or a 20 fraction prostate course is going to be somehow tragic. Because I know that giving that a large dose to prostate tissue is not an issue. I'm happy to do it on SBRT as well, based on the single arm studies that have shown that it's safe with SBRT to give a focal boost, and people have gone up to 50 gray to the tumor and patients have done well. So I think that we've shown that it's safe. We have a randomized trial showing that intensifying the dose to the tumor makes sense. I'm comfortable extrapolating to all fractionation schemes between 5 and 40. Don't do 40 much, but if you were going to, I think that that's okay. And then we've done basically EQD2 BED calculations to come up with what that focal boost dose is. To be honest, we're a little bit more conservative than what was done on Flame, just because you're rolling out something new. But I have some friends in private practice who say, I'm not going to do anything that doesn't have a trial to back it up because I don't want to be liable. And it's reasonable. But my response would be then, and I have colleagues in other countries that say the same thing, but I would say the evidence for SBRT is that it's convenient for patients with a slight increase in side effects versus conventional radiation. The evidence for focal boost is that it improves patients' outcomes without causing an increase in side effects. So unless there's a compelling logistical reason why the patient needs to have 5 fractions, if you're only willing to do focal boost or SBRT, it seems like a no-brainer to me that what you should be doing is focal boost. I just go to focal boost with SBRT because I'm okay with that. But if you want to hold the line on it has to be 35 fractions, then by all means do 35 fractions and do focal boost. But don't give the patient an SBRT treatment that's been shown to be non-inferior to the control arm of Flame. Right? They both have the same control arm, and one of them improves patients' chance of cure. Unless the patient is willing to compromise on, local control on the grounds of I live far away. That's what we know. Now, maybe because if you're doing PACE B style SBRT and you're giving, 8 gray times 5 to the GT to the prostate, 8 gray for the, times 5 for 40. And you think, well, that's a higher BED anyway than what was done for conventional. I hear you. That's okay. But again, it's not like we've proven in PACE B that the outcomes were better with SBRT, oncologic outcomes. Right? It may just be a patient population issue. PACE B, a lot of those patients had fairly favorable disease. And so it's going to be hard to show a difference. Maybe SBRT is more effective at 40 gray and 5 fractions than conventional or moderate hypofractionated in high-risk disease. But nobody knows that. That's just it's a reasonable-ish hypothesis, okay? But I'd err on the side of doing focal boost for everybody that you can do it for reasonably. So not patients that have metastatic disease where we're just treating essentially kind of palliatively, not patients with severe issues already, major medical comorbidities. But for my routine patients, almost all of them get focal boost. Virtually everybody.
It looks like we have maybe our last question in the chat if you still have time, Dr. Seibert.
Yeah.
So,
I didn't see it. What did it say?
That's okay. It just showed up. Do you differentiate between LDR versus HDR when you discuss not using brachytherapy with your patients?
Not using brachytherapy. That's an interesting way to ask it. Yeah, I mean, I think that either is fine. They work. It's not like a new treatment that we don't know if it works, right? I mean, brachytherapy is an effective way of delivering radiation therapy. We know radiation works. We know it kills cancer. We know it works on prostate cancer. I have no objection to people getting brachytherapy. But if they ask me, should I do brachytherapy or should I do external beam with focal boost? Because I have a clinical trial showing me a benefit with that, I just follow the evidence. There's level 1 evidence for the one option. There's not for the other. That's it. Do I distinguish between HDR and LDR? Not really. I mean, I see the dosimetric advantages to HDR. It's appealing. But I don't have a trial showing me that patients getting HDR are better off, and it's still an invasive procedure. It still probably causes more side effects. Again, the onus is on us as the field to develop the evidence to establish why we should be offering some treatment versus some other treatment. And I just don't think that we've done it for brachytherapy, nor have we done it for prostate for protons. I don't object to anybody getting those if they want, but I won't push anybody to get any of those.
Thanks for answering that. I just we do HDR mainly at VCU, so that's the only reason why I was asking. We
Yeah.
counsel our patients basically saying like, oh, we do HDR, not LDR, because there's like less long-term side effects is mostly what we say. So I was just curious if you're kind of lumping LDR and HDR into that. But we are doing, obviously we have the Meridian as well. So that's been really fun to use. Yeah. I
Oh
do.
no, it's good. And we do, we do brachytherapy here too. Again, not
Yeah,
opposed. And I think that the idea of HDR having less side effects in the long run is a good one, but I'd like to see it proven.
sure. That makes sense. Yeah, I mean it's an invasive procedure, like you're
Yeah,
saying. Always weary. Like you have anesthesia risks, right? Like
exactly. You've
there's anesthesia.
added a lot of risk. What is the benefit of that additional risk? It's the same argument that I make when I have a patient with, really high risk prostate cancer who's asking, should I get surgery? So, I mean, there's an argument for removing the tumor, right? It might be that it's better to get that high grade tumor completely out because it could recur right in that same spot after radiation. And it's not going to recur in that exact same spot if you take the prostate out. But the odds of that patient not needing radiation and ADT are so low that you're basically saying, in addition to radiation and ADT, I'm going to add surgery. Well, I know that causes harms, and I don't know if there's a benefit. So I would enthusiastically enroll on such randomized trial. But if we don't have one, it's hard to push patients to do that additional, take that anesthesia risk, take that risk of, incontinence and impotence without some kind of compelling reason. Some will want to, and that's okay. It's not going to hurt their oncologic outcomes, as far as I can tell. But I don't know that the benefit outweighs the risk, and I feel the same way about brachytherapy boost. I just don't know yet if it works. If it does, I might even go back and retrain. I mean, I was trained to do brachytherapy, but I haven't done it in a long time. I don't know because I run a lab and I'm pretty busy. But the idea is there. If you show it's a real big benefit, I will either make sure I refer all those patients to my partners that do it, or I'll relearn how to do it myself. But until we have that trial, and I would help lead the trial, but I just don't see where's the funding. It gets tricky. I'm not trying to pile on to people. I just again think that it's on us to figure out how to justify additional risk.
Thank you so much, Dr. Seibert. I'm gonna throw one more thing into the ring
Okay.
for brachytherapy, and that, you've taught us some excellent contouring mechanisms for outlining the prostate and the urethra, and hopefully we have trials or something that gives us some data that if we can better delineate the urethra with a pre-plan MRI or post-plan, we've done that for a long time here with LDR, and we've just started doing it with HDR. Maybe we'll get trial or some data that kind of correlates better the toxicity risk for those patients. But,
Yeah.
until we've had this MRI imaging and the ability to see the actual anatomy, we couldn't do that. So we'll see. Hopefully
That's
we'll
right.
have data both for brachytherapy and protons and additional focal boost treatment trials down the road with this excellent MRI contouring, which you led us through very beautifully. So I don't
Thank
think we
you.
have any other questions right now. Any last parting comments for us, Dr. Seibert?
No, I just think it's awesome that you guys took the time to come at night and learn a little bit about this stuff, and hopefully it was useful. And, that's the kind of mentality that's going to make care better because, you're trying to learn. Nobody's making you be here, and you're not getting any bonus points anywhere. I can't even see who's on. So, even I don't know. I just congratulations. Thank you for being in the field, for caring and trying to make your ability to treat patients as good as possible. And I love the questions and the thinking. And somebody in this group might be the one that shows that there is a tremendous advantage to say HDR or to any of these other things. And everything's possible. All of those things we don't know. So stick with it. If you have a question, if you think that you've got an idea for how you can make things better, try it. I showed you one of mine, this rad target one. We're going to lower the dose. We don't know if it's going to work. We have to tell patients that. I don't know. We know that a lot of recurrences didn't happen outside of the GTV at 70 gray and 35 fractions, or 77 gray and 35 fractions. We don't know what happens when you lower the dose. So it's taking a chance with the hope that maybe we're going to lower side effects. It's okay to ask those questions. Just push the field to ask them in randomized trials that actually give answers so that we can avoid fun but ultimately unresolvable debates and instead move the field forward. So thank you so much for your time.
Dr. Seibert, thank you again for kicking off our series looking at contouring advice from imaging experts in our fields. And thank you so much again for your time. And I think we all learned a ton from you.